going on. So we have other options besides basic radiographs. You can do contrast enhanced radiographs. Now, from what you guys know at the wrist joint, if they inject dye into the wrist joint, it's supposed to stay contained within the wrist joint. Why would it leak into, why would it leak away? What could that tell us? What could be disrupted there? Joint capsule, TSC, could be a fracture in one of the bones. In this case, we end up seeing a really nice disruption, scapulonate dissociation here. Okay. So the dye will then leak out. So a lot of times you can have a standard film done and they'll inject that radioactive contrast dye in there. And then you've heard of conventional tomography, which was the early form of image slices. Any of you ever hear of tomograms? It's pretty outdated technology now, but these were the precursors to CT scans and so on and so forth. An X-ray beam and a film receptor are moving around the body, so the downside is there's a lot of radiation with these. These are no longer utilized, and that's part of the reason that technology has gone on to be so much better. So we have something now called computed tomography. And depending on which definition you use, it's all the same thing. Computer CT scan is computed tomography, CAT is computed axial. So some people say, well, what's the difference? There really isn't. Okay. High density X-ray beam is sourced and displayed, and the digital image receptors are moved around the body in sequence. And the process is managed by a technician in the computer, and they take individual slices of the tissue in all different directions. The sliced cross-sectional images are the result, and they can be between 0.3 and 1.5 centimeters thick. That's all controlled by the technician. Smaller slices are going to use in the area when the anatomy is rapidly changing, because if you take a slice that's this thick, the computer takes an average reading from that, and you could miss a bunch of stuff in there if you were in a transitional area. And the computer reformats the image into a 3D format. This is pretty amazing stuff. And the old CTs would go slice, stop, slice, stop, slice, stop. They moved the patient through because the image, the receptors stayed in the same place. So if you ever saw a patient on one of those things, the little electronic gurney would go, can you move forward a little bit, stop, do the image, move forward a little bit more, do the image, move forward a little bit more. The problem with that is you lose, you have the possibility to lose images between the slices. So they invented spiral, or what's called volumetric scanning, which the patient in the table moves slowly but continuously. The data from the slices overlap, so you avoid missing information. The images can be constructed again, all based on computer programs, and there are faster scan times, which means less radiation. And here is the old volumetric one where the person was underneath in the X-ray tube and the detectors, when everything went around in a circle, and it would stop and cycle as you move the gurney back and forth. The spiral one, the gurney here moves real slowly, but the scanning is done constantly as the X-ray beam and the receptor are constantly rotating inside that gantry. So viewing CT images, you want to view them as if you're standing at the feet of a supine patient. So that's kind of bizarre. So basically, you want to view them, I'm not going to go supine, I'll go long sitting, as if you were standing below my feet. So what you're going to see is left and right sides are opposite. You have to remember that. Because remember, if you're looking up my feet, my right foot's going to be on your left side. Okay? The tissue densities vary. Denser tissues are going to be white to light gray, and less dense tissues are going to be dark gray or black. Similar to what happens with radiographs. Okay, if we view a CT image here, notice we put right side and left side. What, in general, what does it look like we're looking at? Just a big, yes, sir, what do you think? It can't be cervical, that's a big vertebrae. This is probably L5 at S1, right? All this thing sticking way out here to the side. Remember your sacrum is really wide, okay? So, if we look at this, number one would be cortical bone. And what bone articulates it? This is the right ala of the sacrum, and this is the right SI joint. What bone does this have to be? The ilium. Okay, good. 2 is going to be cancellous bone. 3 is going to be the paraspinal musculature. 4 is going to be cerebrospinal fluid, which is in here. 5 is going to be fat, and 6 is going to be gas. Now, why is there gas on a vertebrae? It's not always there. We mentioned this in the lumbar spine. What phenomenon was that called if you have nitrogen gas in a vertebrae? We mentioned it briefly. We said we're going to talk about it in imaging. It's called a vacuum phenomenon. The vertebrae degenerate. They generate gas. Okay, and what articulation is highlighted by 7 here? What does that look like? Well, what else helps join L5 to S1? So, what articulation is that? Keyword there is what articulation. What's that, John? Picture this. Vertebrae out here, with the set joints back here. This has to be what? Spinous process. Okay. You're getting your orientation a little bit now. Okay. And the image is pretty lousy, isn't it? Not a really good image at all. So what are the advantages? It's best to image loose bodies and joints, subtle and complex fractures and joint degenerative changes. They show up really well. It's the image modality of choice for cortical and cancellous bone, as in stress reactions or compression fractures. They show up really well on CT. The person at the computer can enhance and magnify the image. You can zero in on a specific point, which is really nice. You can view the image at different angles, and they're relatively high sensitivity to different densities. The disadvantages, like we said, if 2 tissues fall in that voxel or window, the computer says, that's a really dark and a really bright, so we're just going to make it an average gray, and that might cause you to miss something. So they have to do the slices really thin to problem. You can't distinguish the histological makeup of the tissues. In other words, if there's a tumor and it has the same density as the muscle, you can't tell the difference. So what are we looking at here? And which side is problematic? This will stretch your brain a little bit. But it's something you guys have seen before. Okay. This is human. You're looking from below. Remember, you're at their feet. It's a slice through the body. Yes. Yeah, it's the SI joint. Here's the sacrum, which kind of looks like a mountain lion. Looks like a mountain lion with big ears. Okay. Here's the right SI, and here's the left SI joint. And look at the right SI joint. Totally obliterated. We don't know why it's obliterated, but we know it's obliterated. From what you remember from the SI joint lecture, what SI diseases can cause obliteration of the SI joint?
Jeepers creepers.
What are your top 3? Ankylosing spondylitis. Another one that's bacteria related. Tuberculosis, remember that? Talked about that. What's another one? Less common in the SI joint, more common in the great toe. Gout. But either way, this is a perfectly normal left SI joint and a nondescript obliterated right SI joint. Okay? And that's all we can say. What might you find on a clinical exam on this person? On your sacral thrust test, what might happen? What might be their response? Could be pain, could be no motion at all, or it could be motion with pain, because we don't know whether this is soft tissue, if it's articular cartilage in nature or not. So any of your sacral stress tests could provoke symptoms on that side. And remember, it's the pain-provoking tests that have the high reliability. So this says, oh, there's something going on at your left SI, at your right SI joint. But we have no idea what it is, so you have to do your clinical tests to find out. Nuclear imaging. In the old days, it was known as scintigraphy. It's a form of nuclear medical imaging. You use radioisotopes. These are the things that get injected to you, and when you go to the bathroom, you pee radioactive stuff for a day or two. It's kind of interesting. But the radioisotopes serve as biologic tracers. So there's a time period needed for these isotopes. Once they inject them, they go through your body, and then they tend to settle in areas where there's altered metabolism, as in increased metabolism, energy problems. So if there's a muscle tear, if there's a joint that's irritated, if there's a fracture, the radioisotopes will settle in that area. So the metabolic activity is what's targeted, and technetium-99 is the common one. You'll read that on radiographic reports, but there's so many different others now. You can get single plane and cross-sectional images. Okay, here's an example of a sequential analysis. The perfusion image means the radioisotope is starting to show up in the person's limbs, and in this case, it's both lower extremities, both calf areas. Okay. This is when it's maximally full. Both calves are full of the isotope. And then all the isotope drains out, but look what's left. This is what's called a hot spot. There's an area of increased metabolic activity once all the radioisotopes have drained off, which means some of them stayed behind because they will stay where the metabolism is increased. What do we think is going on here? Mid to lower shaft of the tibia. Stress reaction, stress fracture. Yeah, this is one of the ways they used to be able to diagnose it, but it's a killer because it's you're absorbing radiation. So it's an expensive way to do it, but if you can't find one, these will always pick them up. So they will still use these, but not necessarily first run. Mostly utilized for this delayed image to see where the maximum uptake was in the tissues, because you can't tell anything from these first two images. But you have to let the perfusion, the blood pool, and then the delayed image all occur so you can see where the maximum uptake was. And they can be utilized to show the sequence of perfusion. Now, if there was a blockage, you could see a lack of perfusion, and that can give you hints as well. Okay. So, good examples of nuclear imaging: static scans, thyroid, lung, and liver, looking for metabolic performance. Are the organs functioning like they should? A bone scan used for detecting arthritis, stress reactions, tumors, infections, and metabolic disease. PET scans, positron emission tomography, provides an excellent in-depth index of metabolism within organs, so they essentially use a CT scan with a nuclear radioisotope. Single photon emission, computed tomography, or a SPECT scan, you can actually watch the tracer isotope move. That's cool stuff. You might have seen this on some Discovery Channel or 60-minute things where they have full color images of the brain and you watch the isotope change colors as it moves from one portion of the brain to another. Okay, lots of that. And you can get all kinds of cool images, and this technology is changing by the week. So what we're even talking about now is probably old school, and because I put this lecture together a few months ago, there's probably new things out since then. The advantage is you get an image of metabolic activity, which is you don't get with anything else. The disadvantage is a really lousy detail, which you saw. They show you the area of the problem, but they tell you nothing about what the problem might be. They're unable to detect small lesions because they're drawn on such a big scale, and the patients are exposed to ionizing radiation, which is never a good thing. Everybody good with those? Okay, we got a couple of different things here. So if we look at this, and we go through our bone scan example, looking at this one, what do we think this might show? Obviously it's of the hand, but if we look at the wrist and the MP and the IP joints and the IP joint and the MP joints all the way across, think back to Dr. Deers' in my lecture on the ortho hand. What condition does that really highlight?
RA.
Right. Yeah. Okay. If we look up here, we see lots of areas highlighted. Ankle, knee, pelvis, both shoulders and parts of the spine, front and back. That's showing us multiple examples of just degenerative joint disease. You don't know whether it's RA or OA, but the joints are swollen in all of those areas. Notice that we got a little bit of uptake right here. What muscle lives right over there? See, everything else is fine, but there's an increased uptake right here. We don't know. I mean, it's TFL or what? Or if it was more on the posterior side, what would it be? Or more on the lateral side? This actually, with additional testing, this is what myositis acidic and the gluteus medius and stuff. It showed up as just as an increased uptake in the gluteus medius, and then they had to do more testing. And usually what you find out is if you do a radiograph, within the muscle, you'll see the bone, and you won't see the muscle, but you see a thin line, like a thread of bony, of bright white tissue, and it's sometimes as small as a thread within the muscle, and that's what myositis acidic look like. But it's an ongoing inflammatory thing, so they first detected it with the bone scan. And this person has large hot spots or increased uptake spots in the glenohumeral joint, on the scapula, part of the thoracic spine, and in the pelvis. What do you think's going on here? Do you think it's not good? Bony metastases. Many sites. Bony metastasis to the upper and the lower extremity, upper extremity, spine, and pelvis. Doesn't tell you what kind, but it just shows that there's increased uptake. Now, that would all need to be investigated, but when they do a biopsy or they do further testing, they found out that it was metastatic original tumor. Yeah.
From the picture above that, you just know it's more of a metastasis because it's the full bone and not just a joint?
My guess is they looked at all of these and they probably did blood work on top of it, and there were no markers for metastases here. And there were markers. Metastases causes bone demineralization, among other things, and there were additional blood markers here. So you don't get it just by the bone scan alone. Plus, it goes on patient history. Do they have a history of tumor that may have come back, and they're isolated to one area? So there's a lot more that goes into it. You don't get it just by this. But this helps you determine where what we call hotspots, where the increased metabolism really lies. Again, we can't make too many inferences from the imaging, but it does give you some locality, and a good physician would go and say, all right, we need to do more testing, and let's find out, is it OA, is it a tumor, and they'll use all of it. MRI, we'll do this, we'll start on this and then we'll break for lunch. Anybody here have an MRI? Live through that? Do you like it, Megan? No, not me neither, I had 2 of them. Jake, did you have one?
Yeah, when I was real little, I don't
Don't
remember.
remember much, Megan, anything you wanna share?
The machine was really loud, and then like had to wear headphones, but you could hear the machine. Luckily, mine was on my knee, so I didn't have to actually like go into the machine very far,
Yeah.
but it's fairly tight space.
If you're claustrophobic, it's really tough. And I had one of this area, and it sounded like there was a jackhammer about to break my head open. Because the noise was so loud, because you're right inside the bank. It's really impressive stuff. But it scares the daylights out of it. And yeah, I'm not terribly claustrophobic, but by the time that thing was over, I was ready to get out of it. So you can get cross-sectional images in all 3 planes like you can do with CT. We use magnetic field and radio frequency wave pulses to cause the hydrogen nuclei to emit a signal. The nice thing is no radiation. Signals from the hydrogen nuclei. What do we call hydrogen nuclei? What's the standard term? How many hydrogen nuclei are there in an atom? 1 proton. So we call it a proton. Okay? So when people say the protons, they're actually talking about the hydrogen nuclei. Differential tissues emit different signals, and the computer and specialized software can do amazing things with this. So hydrogen atoms are present in all tissues, and the MRI images the nuclei, or the protons, of the hydrogen atoms. The magnetic field causes the protons to kind of line up. You'll see that in a second. Then they introduce a radio frequency pulse, which deflects and disorganizes the protons. When you terminate the electric pulse, the protons gradually return to their normal alignment because they're in that magnetic field. Protons emit a signal when they return to normal alignment, and they also emit a signal when they lose their transverse magnification. So they are oriented this way, but within the proton, they're oriented this way as well. So they move amongst themselves and they move within themselves, and both emit a signal. And if you think about this from just how did they ever figure this out point of view, it's pretty amazing. I mean, who actually thought of this? Well, these are the nuclear physicists for it. Okay. Hydrogen atoms, we said the MRI images those. This is pretty much a repeat of the slide before, but the magnetic field causes the protons to line up. Here they're not in the magnetic field. And you all, are you familiar with the magnetic field in an MRI? You see all the signs when you go by an MRI room? People have been injured with those massive 50-pound O2 tanks flying across the room. The magnets are that powerful. So that's why you can't have those things anywhere near an MRI machine. This is not a magnet that'll just pull your ring off your finger. It could move a car if it needed to. You can use a really strong magnet. So, the magnetic field causes the protons to line up. Because here they are just hanging out in space. Here they're lined up, and then a radio frequency pulse is introduced, which lines them up, but it also spins them on their own axes. And then you turn the frequency off, and you let these guys fall back to their normal position. So, protons gradually return to their normal alignment in the magnetic field. Sensors detect weak signals from the protons as they realign. The energy they absorb while being displaced out of line is released. So they had to take on energy, and now we're getting rid of that. You've heard the term T1 MRI or T1 recovery. That's when they return to their longitudinal alignment, which is just this way amongst each other. When they return to their normal rotational position, that's a T2, or relaxation of transverse magnification. So all the image that you get is done as the protons fall back to their normal alignment. Okay, understand that part. So the signal is different for protons of different tissues. That's why tendon to bone to ligament to lung tissue, whatever, can really show dramatic differences. The released energy induces a current in the receiver coil in the MR machine, and the data is collected and processed into images by highly sophisticated software and really, really fabulous technicians that can manage that stuff. The computer program constructs detailed images from the mathematical calculations from all the signals. Disease processes alter the proton relaxation characteristics of normal tissue, therefore they become visible on the MR image. So it's really pretty amazing stuff. Viewing MRs is just like viewing CT. If you're having a frontal image, so they're gonna take an image and look at you this way, you view as if you're facing the patient. But because it's reversed, my right side will be on your left. You have to remember you're flipping them around. Transverse axial images view from below, like you're looking at the bottom of their feet. Sagittal image view as if you're facing the patient from the side. So you'll see a sagittal image and we'll show you, and you just look at it that way. Okay. Here's a sagittal image of the spine. The T1 image measures energy from tissues that rapidly give up energy that's early in that return to normal alignment process. You get really good detail. Fat and bone marrow are bright, water is dark. Here's your cerebral spinal fluid. It's a big band of dark tissue. Notice the discs have a lot of water in them. They're dark as well. Okay? The T2 image is that late decay return. Less sharp anatomic detail, really good for picking up inflammation because the water shows up bright. Fat and bone marrow are showing up as dark. So look at the cerebrospinal fluid on this one. See how bright it is? And why does it suddenly go from bright to gray? Why does it suddenly go from black to gray? Spinal cord. All of a sudden the actual tissue of the spinal cord is coming into play. So WW2, water is white on T2, with T2, if you want to use a mnemonic. Remember that? That's kind of a nice one. World War II, water is white on T2. There's other ones out there. I tend to like that one because I'm a bit of a history fan. Signal intensity in T1, T2, and something we're going to call proton density is linked to the concentration of water in the hydrogen ion, and that's where it comes. And there are different types of MRI images. There's even more now. There's like 7 or 8 more that we're not going to talk about because we'll just get lost in the detail. Short tau inversion recovery is what STIR means. Short tau inversion recovery. Tau being a type of wavelength. Short tau inversion recovery, most sensitive for imaging occult fractures. What's an occult fracture? What? No, it doesn't mean you practice witchcraft. What does occult, the word occult mean? Hard to see. So, real tough to see fractures initially, like a new cranial base fracture or a new stress fracture sometimes will show up. Okay. Similar to T2, but greater emphasis on structures and greater amounts of fluid and fairly poor resolution. Proton density is based even more so on the density of protons in addition to the release of the energy with decay, similar to T1 did with nice decay. Okay. You're going to hear about fat suppressed MRs, non-fat suppressed MRs, all different kinds. As they occur within the course, we'll mention them, but I don't want to burden you with lots of information now because it just gets too crazy. Okay. If we look at a T1, a T2, a STIR, a T1, a proton density, a T2, and a STIR, where do you see the defect the best? I'll give you a hint, the defects on the tibia. Yeah. Person has a compression fracture of the tibial plateau. And all those properties we talked about, we rely on the physician and the technician to determine the best image. And they can do one MRI scan, and they can do all these calculations at the beginning, so they don't have to do 4 repeats. So it's really pretty cool. So obviously, you see the tibia doesn't look quite right here, it's a little dark. It looks a little shady here. You see kind of a grayish delineation here, but all of a sudden, this one highlights there's a real change in the tissue. So just take that for what it's worth right now. And it's a good time to take a break. We'll talk about DWIs after lunch. Okay, so we'll be back at 1 o'clock. Try to be right on